Bismillahirrahmanirrahim. So in today's video we will talk something about practical. So this video is mainly for HOs and PGs who are working in the emergency department. So why you have to check the oxygen saturation of each and every patient before coming into pathophysiology of the COVID-19 patient. We have to first follow the algorithm. So in the emergency department, you have to check the oxygen sats of each and every patient, even if asymptomatic. Asymptomatic in the context that either the person is hiding the history of cough, fever, shortness of breath, or the patient is in the ER because of some other non-respiratory and non-COVID complaints. So if the person is asymptomatic, let's for example say we have seen in the ER a lot of patients, they are not in distress, they are having no dyspnea, but when you check the SATs of these patients, that is 71%, 76%. Now why? So before coming to the question why, we first should follow this algorithm. If the person is asymptomatic, next step is check the oxygen sats. If that is less than 90, do the chest x-ray and look for the typical pattern of COVID-19. We have to focus on the peripheries of the x-ray as well. Suppose this is the x-ray, so we have to focus on the peripheries of the x-ray as well. Now there is a confusion in a normal x-ray. If you take a normal x-ray, you will see that there is some opacity in the peripheries. That opacity is because of two reasons. One is the scapula, it is scapular shadow. The other is the x-ray, the central area are focused more as compared to the periphery. So if there are less rays passing through that, so we are having opacity. But how would you differentiate between that opacity and the pathological opacity? Well, that opacity that is due to quality of the film, that is usually uniform, and that covers all the area from top to bottom. But the pathology or the opacity or the GGOs that are due to COVID-19, they are not uniform. In some area they are thin, in some area they come out like this and then go back. Even if you are having a doubt and there is a confusion whether this opacity is pathological or due to the poor quality of the film, what you should do? HRCT test. That will clear the picture at all. But in my opinion, if the patient is not maintaining SATs in the absence of chronic lung disease, having no previous comorbids regarding the pulmonary physiology and pathology, treat and take it as COVID-19 until and unless proven otherwise. So on X-ray, that will show typical pattern. You have to focus on peripheries, and next step is HRCT if there is confusion. Now a lot of people, they are advising the HRCT chest in spite of the X-ray suggestive of COVID-19. Now, is that making any difference in management? No, that is not making any difference in management. So in my opinion, if the chest ray is suggestive of COVID-19, so CT should not be done. But if there is a confusion and the picture is not clear on the chest x-ray, of course you should move one step forward and you should go for the HRCT chest. Now if a person is symptomatic in the context of COVID-19, cough, fever and shortness of breath, whether the patient is maintaining the SATs or not, advise the chest x-ray and look for the typical pattern. Now the typical pattern is the bilateral opacity, usually peripherally sparing the central zone. That is in initial stages. What happens in the later stages, it involves the central zone as well. So the bilateral patches, bilateral opacity, think of COVID-19 in the top, then second viral pneumonia, that is influenza, parainfluenza, rhinovirus, adenovirus, respiratory syncytial virus, and involve the isolation. Now coming toward the pathophysiology. On the left side, this is a typical non-COVID ARDS. while this one is the COVID. First, coming toward the typical non-COVID ARDS. Now, what is the concept of silent hypoxia? Silent hypoxia means patient is having decreased SATs, saturation is decreased, but there is no dyspnea. There is no respiratory distress. The respiratory rate is normal. If you check the oxygen SATs, that is very low. So what happens in the typical non-COVID ARDS? The alveoli, they become filled with inflammatory exudate, with infectious agent, infectious substances. What happens? The alveoli, the sponginess, the contractile texture of the lung in the alveoli, that is lost. So with each breath, normally what happens? The lung is compliant. It expands, compress, expands, compress. When they become filled with fluid, they are not expanding and compressing, expand. So they become rigid. When they become rigid, I am talking about typical ARDS. So the airway collapse. When the airway collapse, there is decreased compliance. When there is decreased compliance, there is actually CO2 retention. And this is the CO2 retention that activates the respiratory center and causes respiratory distress. Of course, hypoxemia and hypoxia is also involved in the stimulation of respiratory center. But it is said, according to the USMLE and Lecturio, that CO2 retention is the main culprit that causes the dyspnea. And CO2 retention is because of decreased compliance. What happens in a typical ARDS? If you increase the PEEP, what happens? They pop up the alveoli. When they pop up the alveoli, the saturation improves. I'm talking about ventilator setting if you increase the PEEP. Now coming toward the corona. What happens in the corona? Of course, there is inflammatory exudates in the alveoli, but the inflammatory exudates in case of COVID-19 is very less. But there is thrombosis in corona patient. What happens if the alveoli are not filled with an inflammatory exudate? So they are compliant. Compliance is not lost. What happens? Compliance is normal, and person is washing the CO2, so the respiratory center is not stimulated and the person is not dyspneic. So that is the concept of silent hypoxia. And the pathophysiology in COVID-19 is actually thrombosis. If you increase the PEEP in the COVID-19 patient, what happens? Alveoli are already compliant. That does not improve the saturation. That worsens the patient. That causes the alveolar trauma. But when you increase the FiO2, saturation improves. What does it mean? It means the alveoli is functional. It is actually the thrombosis that is the pathophysiology of the COVID-19. And that is actually high altitude like sickness. You are giving more oxygen, oxygenation is improving. If you are increasing the PEEP, the alveoli are already popping up. There is no role of PEEP in COVID-19, and there is a very little role as compared to typical ARDS. There is a role of FiO2. You have to increase the FiO2 oxygen saturation. Keeping in view the thrombosis phenomena, if you see the chest X-ray, from where the opacity starts, it's from the periphery to the center. And if you take the X-ray of the pulmonary embolism, from where the opacity starts, periphery to the center. So it gave us idea that the main pathology is in COVID-19 is thrombosis, because the pulmonary embolism X-ray or CT and the X-ray of the COVID-19 or the CT of 19 is typical to that of pulmonary embolism. That's why Clexane has got some role, provided that contraindication or ruled out. So this was a short message to check the oxygen stats of each and every patient in the ER.